Please don't wait too long to give the epinephrine. Kingsley here, your ultrasound trained, board certified emergency medicine doc, and I'm talking about anaphylaxis, essentially a life-threatening allergic reaction. It's a type 1 allergic reaction, which means that your body is seeing an allergen, typically for the second time, and these IgE antibodies that you make are providing an overly robust response to this allergen. Typically something pretty mundane, like fish, shrimp, peanut butter, you know the drill. Now, epinephrine is the one drug proven to help with mortality and morbidity. We use other drugs to help with the symptoms, but remember, epinephrine is key, and that's usually going to be 0.3 milligrams or 0.5 milligrams given intramuscularly, typically in the thigh, at a concentration of 1 to 1,000. So what are we looking for when it comes to anaphylaxis? Well, clinically, I'm looking for A, B, C, D, and S. It's basically our airway, breathing, circulation, digestive tract, and skin. When it comes to airway, I'm looking for, is there any signs of lip swelling, tongue swelling? Breathing, is there any signs of difficulty breathing? There's wheezing on a clinical exam. Circulation, are they hypotensive? It looks like they're in basically distributive shock. Digestive system, are they nauseous? Are they having diarrhea? And S is skin. Are they having a rash? Are they itchy? There are some adjunctive treatments and some other considerations. So our mainstay other adjunctive treatment is going to really be steroids. Typically, it's going to be methylprednisolone, typically given IV, or hydrocortisone. Now, when it comes to the A, B, C, D's, and S's, for our airway, remember, there can be tongue swelling, there can be lip swelling. You might really think about taking that airway just to protect the patient, and that's typically going to be endotracheal intubation. When it comes to that breathing, patients can be tachypnic, really short of breath, be dealing with a lot of wheezing, and sometimes we can try things like bronchodilators, such as an albuterol nebulizer. For circulation, especially with them having possible distributive shock and being hypotensive, we can support that blood pressure with IV fluids and sometimes even vasopressors. When it comes to that digestive tract, that nausea can really be pretty tough. So you can use medications such as Reglan or Zofran to try to help with that. And then when it comes to the S or that skin, they can have that itchiness, they can have the rash, and that's typically when we're going to use our histamine blockers, our H1 and our H2 blockers, such as Benadryl and famotidine, respectively. So you've treated your patient and they're looking much better. What's next? Well, it's important to remember that roughly 10 to 20% of patients can have a biphasic reaction. This just means that they're going to have some type of secondary wave of symptoms where it looks like they're having that allergic reaction symptoms again. So typically, we're going to make sure that we wash our patients from anywhere from 4 to 6 hours. There's really no rule of thumb, but most people would agree that 4 hours is probably the minimum. Then we want to make sure that when it's time for discharge, that we're going to be doing a couple things. We're going to be sending these patients home to follow up with an allergist if they don't already have one, especially if this is their first time presenting with anaphylaxis or they don't exactly know what the actual cause is, as well as send them a prescription for an EpiPen and also a prescription for a couple of days of steroids. Typically, I send patients home with 2 to 3 days of prednisone just to kind of calm down the reaction because that biphasic phase can possibly happen a day or two later. I hope that the next time you have a patient presenting with allergic reaction, especially if there's concern for anaphylaxis, you don't hesitate to pull out that epi. Remember, it's the one drug shown to be life-saving. Kingsley out.